Hello, my name is Priya Kishnani. I'm a clinical and biochemical geneticist at Duke University Medical Center. I truly apologize for not being able to attend ACMG in person. And my talk today is focused on biomarkers in Gaucher disease and evolution through time. Just as a quick overview for this audience, Gaucher disease is due to the enzyme deficiency, glucocerebrosidase, and is due to pathogenic variants in the GBA1 gene. Due to this enzyme deficiency, there is an accumulation in the lipid glucocerebroside, which often is also called glucosylceramide in lysosomes. As I stated earlier, it is an autosomal recessive disease, and at this time, there are more than 400 pathogenic variants described for Gaucher disease, and it is described as the most common sphingolipidosis with an overall prevalence of 1 in 40,000 to 60,000, but amongst individuals of Ashkenazi Jewish descent, the frequency is anywhere from 1 in 500 to 1,000. As all of you do know, the clinical course is extremely variable, and there is a spectrum of involvement from the non-neuronopathic Gaucher disease, or what we know as Gaucher disease type 1, to the most severe end, which is Gaucher disease type 2, which is the acute neuronopathic form. Common to all forms of Gaucher disease is the fact that it is multisystemic. It is a disorder of the reticuloendothelial system, and patients present with splenohepatomegaly and the sequelae from the splenomegaly, which is anemia and thrombocytopenia. There is also significant bone involvement, and the onset for those patients with type 1 Gaucher disease can be as early as within the first few years of life, but could also be in the second decade. But there could be some that have very late presentation or no presentation. As such, you can tell that there is a real important tool that we need, which is how do we monitor our patients with Gaucher disease. So coming to the role of a biomarker, we often question ourselves, what is an ideal biomarker? And I think of it as one which is quantifiable. And for this, what I mean is that it's also readily obtainable in easy to collect samples, which can also be stored easily and can also be transported easily, because then this can be used for diagnosis and screening. The second is that there should be different abundance levels in normal versus patient samples. So again, useful for screening purposes and then being more specific for that particular disease. The third is that it should be the abundant levels are not affected by other factors. Fourth, there should be a relationship to the biology of the disease, which is then understood. And fifth, it reflects the total disease burden or organ-specific disease burden. And so I'm going to try and walk you through the current biomarkers that we have for Gaucher disease, and also how this can be used in the question or in the role of precision medicine, which is a growing part of the healthcare today, and which incorporates biomarker analysis in the diagnostic approach and monitoring of patients with diseases. In this talk today, it will be Gaucher disease, and where we can show that the correlation of the biomarker and clinical laboratory testing results in how we manage these patients. And again, today it would be on Gaucher disease. And the whole hope for precision medicine is optimization of treatment for each individual. So let's now talk about the historic and established biomarkers for Gaucher disease. There have been different biomarkers that have been used. Angiotensin converting enzyme, or ACE. It is associated with Gaucher disease. There is a disease response which you see when treated with enzyme therapy or substrate reduction therapy. However, one has to consider that it's affected by genetic polymorphisms and also the use of ACE inhibitors. Another biomarker, ferritin, again associated with Gaucher disease, not specific, affected by treatment, but it is an acute phase reactant and its value depends also on iron status. Then there is the TRAP, or the acid phosphatase, again associated, not specific, can be a response to therapy, but it's a complex assay. CCL18, again, the same theme, associated, not specific, can be affected by treatment, but it's also present in patients with other relatively common disorders like cancer and autoimmune diseases. Chitotriosidase used a lot in clinical practice, the same theme, but is also elevated in other lysosomal diseases, and that some patients carry a polymorphism resulting in a chitotriosidase deficiency, making it not valuable then in the monitoring of patients with Gaucher disease. And then let's come to lyso-Gb1, also known as glucosylsphingosine. And let me walk you through during this talk of its utility in patients with Gaucher disease. So again, going back, we know chitotriosidase was the first identified Gaucher biomarker. You can see that there is a much higher level in patients with Gaucher disease as compared to normal controls. But once again, as a reminder, in those patients with Gaucher disease, if you look to the extreme right, who also have a chitotriosidase deficiency, it looks like exactly in patients who are unaffected with Gaucher disease. So this is a limitation. And so the value of chito in the clinic is definitely there. And when it's elevated, so in patients who do not carry the polymorphism, you can see a reduction in it with improvements in liver and spleen volumes, also with improvement in hemoglobin and platelet count, etc. But again, as I mentioned to you, that the chitopolymorphism is really present in up to a third of patients with Gaucher disease, and so is a major limitation in terms of a biomarker and a monitoring tool. And again, as a reminder, this is a non-specific biomarker. Other abnormalities, as we've talked about, is the tartrate-resistant acid phosphatase, cathepsins, ferritin, angiotensin-converting enzyme. Again, none of them really qualify as a specific Gaucher disease biomarker. So now let's look at lysosomal globoside degradation. And you can see that in this whole process, glucosylceramide needs to be converted to ceramide, and the enzyme needed for it is the enzyme which is deficient in Gaucher disease, as a result of which what happens is that then there's a buildup of this glucosylceramide. And now let's talk about lyso-Gb1, which is the deacylated form of glucosylceramide. It is more soluble. It is a more soluble lipid, and thus it's able to exit the lysosome, and so causing widespread pathophysiological effects and easy also for monitoring. It has been found to play a primary role in neuronal injury in patients with neuronopathic Gaucher disease, and it's 100 to 1,000-fold elevated in the gray matter. It also has implications in mediating immune dysregulation and skeletal disease in type 1 Gaucher disease, and a significant correlation with other established biomarkers that we talked about, like chito, TRAP, and ACE. Also, a very significant correlation with liver volume, with spleen volume, and with platelet counts. So once again, talking about lyso-Gb1, it's elevated up to 500-fold in plasma of patients with Gaucher disease as compared to healthy controls. Again, it has been shown that monitoring lyso-Gb1 has greater utility than the current biomarkers because it reflects ongoing disease activity in patients on long-term therapy. And in terms of diagnostic support, this biomarker, although the previous biomarkers have not been diagnostic, it can be used to support the diagnosis with enzyme activity and genetic testing, which is done for patients with Gaucher disease. The important part to remember is that lyso-Gb1 is increased in 100% of patients with Gaucher disease with high specificity, and it discriminates better than glucosylceramide, which is the precursor, or not the deacylated form of glucosylceramide, and the levels are in accordance with disease severity. So again, lyso-Gb1, a specific biomarker for Gaucher disease, and is the one that exits the lysosomes, is easily measurable and is better really as when you compare it to glucosylceramide. So here you can see glucosylsphingosine or lyso-Gb1 on the left-hand side versus glucosylceramide, higher levels and a very good separation from controls as compared to glucosylceramide. And then when you look at it here in terms of genotypes, you can see that across the genotypes, you have an increase in the glucosylceramide or the lyso-Gb1 as compared to controls or carriers of Gaucher disease. So does it reflect disease severity? You can see here that it correlates very well with liver volume as well as with spleen volume. And then what is the utility of lyso-Gb1? I'm going to try and share this with you through a clinical vignette. So here is a patient who's 26 years old, a Caucasian male. He has type 1 Gaucher disease. He was diagnosed at 20 months of age via clinical presentation. He had low enzyme activity and had two pathogenic variants, N370S and L44B. He had symptoms which had presented as early as 18 months, including failure to thrive, anemia, and splenohepatomegaly. Enzyme therapy was initiated at 35 units per kilogram every 2 weeks at 22 months at the local institution where he was diagnosed. He was then transferred to Duke at age 4.9 years. At that time, we found that his spleen volume and liver volume were increased. He had normal platelet counts, no developmental delay, no evidence of osseous infarcts on a bone MRI, but he had elevated biomarker in the form of the angiotensin converting enzyme and also an increase in the chitotriosidase. Given his early age of presentation, we increased his dose of IV Cerezyme to 60 units per kilogram every 2 weeks, and this patient remained on ERT through 18 years of age. He did have symptom improvement on enzyme therapy. We followed this patient with various biomarkers, the complete blood count, the chitotriosidase, organ volumes, bone monitoring through DEXA scan and bone MRI, and also the lyso-Gb1 once it became available. So this is the organ volumes on ERT. Just want to show you at 1.8 years, his spleen volume was 16 times the multiples of normal, and the liver volume was 2.3 times multiples of normal. And then you can see close to age 18 years, this had now decreased to 2.2 times multiples of normal and almost a normal liver volume. These are the platelet counts. As you can see, he's in the normal range. And then you can see his chitotriosidase levels are increased, but they're kind of holding steady, but they are not yet in the normal range, which you would have seen lower in what's in the light brown box. And DEXA scans on this patient, as you can see, continues to show that he has osteopenia as measured by his Z-scores on both the spine as well as on the femur. So at this point, I want to discuss this patient further with you. This patient had transitioned to college and also had a significant needle phobia. So my question is, what would you do next for this patient? So what we did was the patient actually requested a switch to substrate reduction therapy with eliglustat. He was actually waiting to turn 18 years of age because the package label reads for patients 18 years of age or greater. He was transitioning to college. As I stated to you, he had a needle phobia. So based on his extensive metabolizer status, he was started on eliglustat at 84 milligrams BID. And I just want to show you the clinical status of this patient. Initially, his biomarkers were stable. After the switch, per the patient, he was missing maybe 1 dose out of his 14 total weekly doses based on the fact that he was receiving it BID. And then on further questioning, he said maybe up to 3 doses every week. So these are the platelet counts following the switch. You can see that he's holding steady, and the dotted line tells you that he's now switched. However, over time, I found that his platelet counts were decreasing some. Second is, as I was monitoring his biomarkers, we now had lyso-Gb1 available. You can see that the chitotriosidase is holding kind of steady. We now had the levels of lyso-Gb1 for the first time. it was clearly above the upper limits of normal. And now over time, what I was observing was that the chitotriosidase had increased some, but the lyso-Gb1 had clearly increased quite significantly. Now, when I was looking at his organ volumes, there was a slight change since his transition to eliglustat. It had now gone up, the spleen volume, to 2.6 times the multiples of norm, and the liver volume was actually still holding quite steady. You can also see that over now a period of time that he was on eliglustat, his spleen volume was now 8.7 times multiples of norm, and the spleen and the liver volume was now 1.5 times multiples of norm. The DEXA scan was actually showing us worsening. He now was osteoporotic, both in the femur Z-score as well as in his spine Z-score. And so what do you think are the potential causes of these worsening biomarkers, the increasing organomegaly, and the worsening DEXA scan in this patient? So the cause for worsening in this particular patient was really compliance. He was reporting that he was missing 1 dose of his 14 total weekly doses. Upon further questioning, he said it might be 3 doses. However, we called up the pharmacy and they actually reported non-compliance because he was not picking up his doses of the eliglustat, indicating that this was more than what the patient was reporting. And so what you can see here is that the biomarker, the lyso-Gb1, was actually extremely helpful in this situation because of the sharp rise that we noted. There was some increase in the chito, but it was not as dramatic. And that this change in the lyso-Gb1 actually preceded the declining platelet counts and also the worsening bone density, which was now recognized as osteoporosis, and also the increase in the liver and spleen volumes, which came up a little bit after that increase, that initial increase that we saw in lyso-Gb1. So we've published this data now on using different clinical vignettes of how we've used the lyso-Gb1 in precision medicine, so in clinical monitoring of patients with Gaucher disease type 1. And so where we are with biomarkers for Gaucher disease, I hope through this case, I've tried to show you that lyso-Gb1 is specific. It's a sensitive biomarker of Gaucher disease. It's a promising marker of disease severity. For monitoring treatment response, of course, we need more studies, and standard methodologies would clarify this further. And in this situation, I've presented it as a reliable treatment response indicator and can be utilized for individualized clinical management.